welcome you all for today's webinar on the second day of Clinical Management of Common Cancers, Newer Perspective. And for this, I would like to invite Dr. Tarachand Gupta, who is Consultant Medical Oncologist at Bhagwan Mahavir Cancer Hospital and Research Center at Jaipur, for the welcome and introductory note. Over to you, sir.
Thank you. Dear seniors and my friends, it's our great pleasure to warmly welcome you to be a part of a virtual conference, Clinical Management of Common Cancer, Newer Perspective, that was started from yesterday. And we yesterday discussed GI cancers and genitourinary cancer. The conference goal is to improve the knowledge and competence of cancer treatment participants to apply practice-changing clinical data and expert recommendation to optimize clinical outcomes for patients receiving therapy in cancer. So experts are likely to help clinicians and practitioners with the role of multiple therapies in a clinical context and discuss how they can effectively contribute to the patient cancer. Today we will discuss the breast cancer journey and to the up to date. And next week we will discussing the head and neck cancer, lung cancer, and ovarian cancer. So so breast cancer is a vast topic. It needs not only the one day. I think it's only a topic which cannot be covered in a single day. It needs 2-3 days at least. But we are trying to comprise the whole the breast so that like for the clinical practice, so that patients can get benefit and within limited time, so that we can discuss all the aspects which are clinically relevant and for the fruitful to the patients. So we will discuss the breast cancer in following heading, like the early breast cancer and hormone positive breast cancer, HER2 positive breast cancer, metastatic breast cancer, and triple negative breast cancer. So for now, I invite for the next first topic that will be discussed and by the Dr. Anubha Bhartwar, medical oncologist and hematologist, Patel Cancer and Super Specialty Hospital, Jalandhar. She will be speaking on management of hormone receptor positive early breast cancer. Ma'am, over to you, ma'am.
Thank you very much. And I definitely agree with you, Dr. Tarachand, that the time allotted for breast cancer is quite short, and especially hormone receptor positive, we know compromises a large majority of our breast cancer patients. So in the time allotted to me, I will be briefly talking about some aspects that are new and upcoming and that I think will be more and more relevant as time goes by. And at the outset, I'd like to thank all the organizers for inviting us here today. Again, we know that hormone receptor positive breast cancer compromises the majority group in breast cancer patients, even in India, even though the percentage-wise, it's a little less as compared to the Western world. So I'll be just briefly focusing on a few things that I think are interesting and upcoming and will have more relevance as time goes by. The first thing that I wanted to talk about is the role of neoadjuvant hormonal therapy. You know, all of us are quite accustomed to giving neoadjuvant chemotherapy to patients who have locally advanced disease, and now with triple negative and HER2 positive disease, you know, more and more neoadjuvant chemotherapy is being given. But is there any role for neoadjuvant hormonal therapy? Traditionally, we think of it for the patient who has a lot of comorbidities and not able to tolerate chemotherapy. However, recent data and outcomes have shown that it is a viable alternative for patient who has hormone receptor positive HER2 negative breast cancer, especially those who have a strong hormone receptor positive expression, more than 50% staining on an Aldrich score of 7 or 8, a low proliferation index of Ki67 less than 10%, and more in the postmenopausal patient and not really for the premenopausal patient. Biomarker analysis is something that's, that's quite upcoming, looking at Ki67, the different recurrence scores, and I'll briefly touch upon Ki67 here also. So there was a large meta-analysis of over 3,000 patients that looked at neoadjuvant endocrine therapy for hormone receptor positive breast cancer. And it actually showed that in the postmenopausal patient who is getting monotherapy with an AI, the outcomes with neoadjuvant chemotherapy and neoadjuvant endocrine therapy were very similar clinical response rates, very similar radiological response rate, a similar breast conservation rate, and much, much lower toxicity. It's not something that we traditionally think about, but the data is there, and it shows that especially for those patients with strong hormone receptor positivity, it could be a significant, it could be an alternative to traditional chemotherapy. In this meta-analysis, the biggest trial that took up this population was about 240 patients with stage 2, stage 3 hormone receptor positive breast cancer. And they were randomized to either exemestane or anastrozole versus 4 cycles of chemotherapy. And here we can see similar path CRs rate, very low actually, but similar rate for a little bit higher rate actually for conservation therapy in the neoadjuvant endocrine therapy group, and no difference in the rates of local recurrence, and of course, less adverse events and less toxicity with neoadjuvant endocrine therapy. And there is now improving upon AI alone. There is a study, which is the NeoMonarch study that we have all heard about. This was an interesting study. It was more of a biomarker analysis. And what they did was they randomized patients into 3 groups who got anastrozole alone, abemaciclib plus anastrozole, or abemaciclib alone. And they did a biopsy at baseline and one after 2 weeks and saw what was the difference in Ki-67. And what they could show was that with the addition of abemaciclib, or just in the abemaciclib alone, the difference drop in Ki-67 was significantly higher with the addition of the CDK4/6 inhibitor. So this is something that we'll probably hear more about in the future. So just closing up neoadjuvant hormone therapy, I think it is something that we could definitely think about for the right patient. So a lot of data has come up in the last 1 or 2 years in the adjuvant space. And the first question is, do we need to do better in the adjuvant space? We do know that a large number of patients with hormone-positive breast cancer will relapse. And most of these recurrences will happen after 5 years. Those who are at the highest risk of a recurrence are the ones with 4 positive lymph nodes, 1 to 3 positive lymph nodes, and either a T3 or a grade 3 histology. So what are the options that we have today in this space? We have the CDK4/6 inhibitors. We have olaparib for the BRCA mutated, and definitely something that has been evolving for many years, but still not very widely accepted, is ovarian function suppression. Briefly talking about the CDK4/6 inhibitors, there have been a number of phase 3 trials looking at the addition of either palbociclib, ribociclib, or abemaciclib in the adjuvant space. Unfortunately, the 2 trials with palbociclib, the PALLAS trial, as well as the Penelope B trial, they were both negative trials. And really, it did not seem to show us that the addition of palbociclib in adjuvant therapy made any difference at all. So the adverse events in the palbociclib arm were a major concern. A large number, more than 66% of patients had at grade 3 or 4 adverse events, and almost 50% of the patients had early discontinuation. The PALLAS trial, they had given it for 2 years. In the Penelope B, they gave it for 1 year. In that trial, there was initially an early separation of the curves at year 2 and year 3. However, as time went by, the curves converged again, and there was no difference in PFS and OS. So a little disappointing, and some people may have thought that was the end of the story, but there are there is one trial that's still ongoing, which is the NATALEE trial looking at ribociclib in the adjuvant space. This is a trial that is ongoing, and we'll probably have results in the next 1 or 2 years. But the one trial that has made a difference and has been a standout this year is the MONARCH E trial, which looked at abemaciclib in patients with high-risk node-positive, hormone-positive, HER2-negative breast cancer who had either received neoadjuvant or adjuvant chemotherapy, could be pre- or post-menopausal. And there were 2 cohorts in this. One was the one with more than 4 positive lymph nodes, or if they had 1 to 3 positive lymph nodes, they had either a higher histological grade of 3 or a tumor that was T3. The second cohort is an interesting cohort. Basically, it consisted of lymph node positive less than 4 without other high-risk features, but it did include patients who had a Ki-67 more than 20%. And these patients were randomized to either endocrine therapy, whichever was the standard chosen by the physician, or abemaciclib for 2 years along with endocrine therapy. And here we can see that for the overall population, the curves start to separate at around 18 months. And at 2 years, the invasive disease-free survival, there is significant difference between the abemaciclib and endocrine therapy group versus the endocrine therapy group alone, with a hazard ratio of 0.7, that was 0.75, that was significant. And if you looked at only those with a high Ki-67, the hazard ratio was even better. again, this is interesting, looking at patients with Ki67 more than 20% versus those with a low Ki67. What we see is that those with high-risk clinical features, the chance of failing is quite high within 2 years. About 11% patients will fail. Abemaciclib, the addition of abemaciclib resulted in 25% reduction in the risk of developing an event in the next 2 years, with an improvement of 3.5%. And for the premenopausal, this improvement was even better. And here we can see that it depends on how you looked at the data, but in the intention to treat, a difference of 5% in the invasive disease-free survival. For those who had a high Ki67 in cohort 1, the difference was 7%. So very, very impressive, and something that we definitely need to think about. But of course, every good things come with the side effects, and there were significant adverse events with the use of abemaciclib. Dose adjustments were seen in almost 68% of patients. 16% discontinued because of adverse events. The most frequent adverse events is similar to what we see in the metastatic usage: diarrhea, neutropenia, less fatigue, arthralgia, and hot flash was more common in the control arm. The severe serious adverse events were obviously more in the group that had abemaciclib with endocrine therapy. So people always ask that, yes, this has made a difference, but what about patient-related outcomes and quality of life and survivorship data? So they looked at patient-related outcomes with adjuvant abemaciclib, and it was felt that this is the side effects that was seen with adjuvant abemaciclib usage were predictable, manageable, and acceptable, especially given the advantages in the high-risk population. Most of the grade 3 adverse events were mostly laboratory events, such as neutropenia. And if you upfront manage the diarrhea, if you are very aggressive about dose adjustments, the addition of abemaciclib did not result in clinically meaningful difference in patients being bothered by treatment-related side events, especially once 3 to 4 months had passed and they had become used to using the newer therapy. So it reduced the risk by 30% of developing an invasive disease-free survival event, and it decreased distant relapse by about 31% at 3 years. For patients with a higher Ki67, the benefit was even greater. And this has now been FDA approved for use in patients with hormone positive, HER2 negative, breast cancer with Ki67 more than 20%, with N1 disease and high-risk features, or N2 and N3 disease. What is interesting is as time goes by, the hazard ratio gets better, different from the other trials, which, as we can see here, which I talked to you about, the Penelope trial, where initially there was a difference, but as time went by, the difference disappeared. So definitely, there is a difference in the metastatic setting. We think of all CDK4/6 inhibitors as being kind of the same, but this does not hold true in the adjuvant space. And there seems to be some difference, either it is in the molecule or a difference in the schedule or the duration of treatment also. Perhaps longer duration is what is required here.
Dr. Anuva, sorry, Dr. Anuva, only
1 minute?
Only 2 minutes left.
Yeah, sure. I'll finish in 2 minutes. So definitely has been incorporated into the guidelines. And as you can see here, I have NCCN and ASCO updates telling us that this is definitely something to think about. Olaparib, I'll briefly touch upon. We are all familiar with the Olympia study. The point here is that it did include high-risk patients who did not achieve a PAT-CR with neoadjuvant therapy, who were hormone receptor positive, or the post-adjuvant chemotherapy hormone receptor positive patient with a high risk of disease more than 4 pathologically confirmed lymph node. And what I wanted to point about here is that the advantage is there even in the hormone receptor positive. Traditionally, we think of it as being triple negative patients as deriving the most benefit. But if we do subset analysis and we look at these forest plots, you can see that the advantage remains even for the high-risk hormone receptor positive patient. The thing that is something we really need to consider for our patients, given the costs and everything of CDK4/6 inhibitors, is ovarian function suppression. What is the role of this in our premenopausal patients? How long should we do it? And when is it too much? So we know that there are 2 trials, the SOFT and the TEXT trials. Most of us are familiar with it, and I won't go into the total details, only to point out that in the SOFT trial, in the low-risk population, who did not receive chemotherapy, it appeared that ovarian function suppression had no benefit. But those that received chemotherapy, definitely the usage of either tamoxifen or exemestane improved outcomes. In the combined analysis, we can see here that there was a significant difference in the 5-year disease-free survival, breast cancer-free survival, and freedom from recurrence of breast cancer at a distant site. And the difference in disease breast cancer free rate was about 5% in the text and 4% in the soft trial. There was an 8-year analysis which kind of solidified these data, and we can see that the use of tamoxifen with ovarian function versus tamoxifen alone, there was a difference about 4%, and with exemestane, the difference is even higher. So in the 12-year update in SABCS this last year, of course, for the low-risk patient, not something we need to be thinking about, but definitely for our high-risk patient, we need to consider ovarian function suppression along with either exemestane or tamoxifen, especially for the younger patient who is receiving chemotherapy. But of course, again, weighing the pros and the cons, and we really have to personalize it and individualize it, considering the late toxic, both the acute and the late toxic effects. So in conclusion, I would say that there are a lot of changes that have taken place in the hormone receptor HER2 negative early breast cancer patients, especially in the adjuvant setting, where we should be considering the use of CDK4/6 inhibitors for our high-risk patient, with the realization that all CDK4/6 inhibitors are not equal. Patient selection is very, very important. And I would say upfront management of toxicities is also very important. For those who are BRCA mutated, germline BRCA mutated, we can consider olaparib. And I would say most important for our Indian population, where cost becomes an issue, something simple, which is ovarian function suppression, would be a very effective strategy for our high-risk premenopausal patient who receives chemotherapy. Thank you very much. I think a lot more will change as time goes by, and we look forward to seeing.
Thank you, Dr. Anwar. And a single question is IDFS is a good surrogate, a good marker for a recommendation of CDK4/6 inhibitor in EBC?
See, I think this is something that we always debate about. The problem is that with the use of overall survival, you're not going to get answers very quickly. It's going because you realize that for hormone receptor positive patients, the relapses occur even after 5 years. Correct.
Yeah.
So it's going to be a little bit hard, but definitely for our high-risk patients, we know that they are the ones who will relapse within 2 years or 3 years, which is the patient population that they are talking about. So I think in that patient population, given their risk of early relapse, usage of this agent and use of IDFS is an appropriate way to look at this data.
And what is the ideal duration of hormone therapy in adjuvant setting?
So again, something that I think for your low-risk patient, 5 years would be sufficient. But I have made it a practice for my high-risk patient who is who is lymph node positive at least. I do consider longer duration of adjuvant therapy, up to 10 years and even longer. I mean, tamoxifen now the data is for 15 years. So I would say you have to individualize, and you definitely have to talk to your patient about the side effects, and you have to monitor, all their things, the osteoporosis, get your DEXAs. I have seen 2-3, honestly, I've seen 2-3 uterine cancers in the last 12 years in our patients who have been on endocrine therapy, but not necessarily more than 5 years. This happened for both the patients. It happened at the 6th year and the 5th year. So those are always things we have to consider.
Thank you, Dr. Anwar, for a nice talk and nicely explaining all the aspects. Now I invite for the next of management of HER2 positive early breast cancer. Dr. Srujana Joga will be speaking, and she is a consultant medical oncology, Rajiv Gandhi Cancer Institute, Delhi.
Are my slides moving?
No, ma'am. Make it full screen. Yeah.
Now are they moving?
Yeah, ma'am.
A very good evening to one and all. Thank you, Tarachan sir, and the organizers for giving me this opportunity to speak on the topic of the management of HER2-positive early breast cancer. So, to go through, as we know, out of all the subtypes of breast cancer, the triple negative, the basal subtype, and the HER2-positive subtype have the worst prognosis, with a 5-year survival around 30 to 40%. So, to improve the prognosis for these patients, we usually go with the neoadjuvant therapy. The purpose for this is to facilitate the maximum resection rates for the primary as well as in the axillary lymph nodes. And we can also know the response of the tumor to the treatment, and accordingly, we can change the adjuvant therapy to improve the prognosis for these patients, thereby decreasing the risk of recurrence and the chance of survival. And last but not the least, we can have a lot of data for basic and translational research in future. So the evidence for the increased breast conservation surgery rates comes from the NACBP B18 trial, where patients who have received neoadjuvant chemotherapy, that is a adriamycin cyclophosphamide, had increased the planned rates and the performed rates had a marked escalation with the use of neoadjuvant chemotherapy, even in T1, T2, and mostly in the T3 tumors. So the meta-analysis done of the 10 randomized clinical trials showed that neoadjuvant is as effective as the adjuvant chemotherapy, as can be seen from the curves here. They almost are getting submerged. The benefit is the same. So this rightly proved the hypothesis that of the Bernard Fisher, that breast cancer is not just a localized disease. It's not based on the anatomical considerations. It's all a systemic disease where the tumor dissemination is dictated by the host tumor biology, and which is going to determine the virulence and the metastatic propensity of the tumor. So this goes way with the neoadjuvant therapy. So we are all very interested about the pathological complete response rates because they translate into the EFS benefits. The least PCR rates are seen with the hormone positive HER2 negative breast cancer with 10%, and triple negatives with only chemotherapy around 30 to 40%, even though with the addition of immunotherapy now and with the addition of carboplatin, it can go as high as to 60 to 70%. In the HER2 positive, we give only chemotherapy, it's around 30%. With the addition of trastuzumab, it increases to 40 to 50% also. But the improvement in the PCR rates does not translate into the overall survival benefit, as can be seen from the curves here. So we have seen why we are giving the neoadjuvant and when should we give. So ideally, by the rule, any patient who gets qualified for adjuvant chemotherapy will also qualify for the neoadjuvant chemotherapy. But this rule is broken. Any operable breast cancers, in HER2 positive breast cancer, especially tumor more than 1 centimeter, are, even though they are node negative, these patients are also eligible for the neoadjuvant therapy as per the latest guidelines by ESMO. And mainly patients who have high tumor volume to breast ratio and want to go ahead with the breast conservation rates, and where the tumor will not be operable, and in patients who are node positive, HER2 positive with high grade tumors, and who are younger patients, they do worse. So these patients need preoperative systemic therapy. So which agents to give in the neoadjuvant? Apart from the chemotherapy, we have seen it's around 30% response rates. When we add trastuzumab or pertuzumab to the neoadjuvant therapy, the pathological complete response rates are going to be increased. The evidence comes from the Neosphere, the Trifina study mainly, which we are going to see. In the Neosphere study, the anthracycline regimen FEC 3 cycles and the taxanes, in addition to the trastuzumab, with or without trastuzumab, was tested. They have taken patients with tumors more than 2 centimeters. So the PAT-CR rates have dramatically increased, especially in patients subsets who have become node negative at surgery. The response rate with the addition of only trastuzumab is 20%, whereas it is 40% when pertuzumab is also added. That is almost doubling of the PCR rates. Whereas when we see in comparison the hormone receptor status, the hormone negative patients and the HER2 new only positive patients had a higher PCR rates of 60% as compared to 30% in the hormone positive subset. The phase 2 Trifina study addressed the cardiac safety with the addition of the dual HER2 block agents to the anthracycline regimen. Interestingly, there is an arm C, which is an anthracycline-free regimen also here. That is the PTCH arm. And here, the PTCH arm has got a almost 60% PAT-CR rates, total PAT-CR rates, as compared to the other arms, which is 50 to 56%. So in the NEO-ALTER trial, where lapatinib was added, along with similar with lapatinib along with trastuzumab, the Jepar-Quinto has addressed this question, and the NACBP B41. These three trials tested the addition of lapatinib to the trastuzumab. Interestingly, NEO-ALTO, the hormone negative cohort as well as the hormone positive cohort both fared well in terms of PCR rates, as opposed to the NEOSPHERE trial, where the benefit is mainly seen in the hormone negative subset. So, and even the PCR rate, PCR responses translated into the DFS benefit. In patients who have achieved PCR, the DFS rates were to the tune around 85 to 90%, whereas patients who did not achieve the pathological complete response rates, the DFS was 75 to 80%. So on the in addition to escalation, we can also de-escalate. Can we avoid anthracyclines because we are giving the trastuzumab as well as the anthracyclines, and over on that, another HER2 blocking agent. There is a dual HER2 blockade. Even though it has been proven that there is no cardiac risk, increased cardiac risk, but still there are some patients who have cardiac risk factors and who are at high risk for cardiac complications. In those patients, can we avoid anthracyclines? This question was addressed in the TRAIN-2 trial, where FEC followed by paclitaxel carboplatin, along with trastuzumab, pertuzumab was one arm, or the 9 cycles of pacli carboplatin, which is paclitaxel was given as weekly schedule, and carboplatin was given in a 3-weekly AUC6 setting, along with the trastuzumab, pertuzumab. Initially, when it was the trial addresses in 2018, the PAT-CR rates were both same in the anthracycline and the non-anthracycline group. And the secondary endpoint, that is the EFS and the OS, was also similar in the anthracycline and non-anthracycline group, with a hazard ratio of 0.9. So for any patient, if we are considering to avoid anthracyclines and who are at high cardiac risk or with high comorbidities or elderly ages, so this is one option in the neoadjuvant setting which we can give these patients. So once the neoadjuvant therapy is completed, we get a histopathological report whether there is a residual disease or not, and based on that, patients who have residual disease have a poor prognosis. So the TTMN, that is trastuzumab emtansine, has been studied in this setting.
Dr.
The 14 cycles.
Only 1 minute left, please.
So it had an invasive disease-free survival benefit of 88 versus 77% after 5 years of follow-up. So the newer therapies being tried are the trastuzumab deruxtecan in the early neoadjuvant setting, the Destiny 11 trial. Whereas the adjuvant therapy, most of the patients need chemotherapy and the HER2 positive. Very rare patients are upfront operable. So the addition of trastuzumab improved the DFS and the OFS rates to 6 to 11%, and the hazard ratio is 0.6. So can we omit anthracyclines? This was addressed in the APT trial, where weekly pacli and trastu given for 12 weeks followed by maintenance trastu for 18 cycles. The 3, 5, and 7-year DFS was almost the same, 90 to 97%. In these patients who are to T less than 3 centimeters and node negative. And even in BCRG 006 trial, TCH regimen, which is anthracycline-free regimen, the node positive or negative status did not matter much in terms of 10-year invasive disease-free survival. Whether can we cut short the duration of the trastuzumab, so that the cost can be cut down and the duration of treatment can be cut down. The meta-analysis of the 12 months versus 6 months analysis showed that the Persephone trial actually showed a benefit because it took a wider non-inferiority margin. And the benefit was seen mostly in the DFS setting, not in the OS setting. So in the affinity trial, which can we escalate with who are at high risk with the addition of pertuzumab. So till last year, we were thinking that only node positive patients would benefit that. But in the latest plenary session presented at ESMO 2022, even this was not statistically significant and did not benefit the patients. So ExtraNet trial addressed the addition of neratinib to 1 more year of trastuzumab. And this showed an increased the IDFS benefit was seen in the hormone receptor positive population, 91 versus 86%. But it is a poor drug to tolerate. And the control trial addressed this question. And when it is given in escalated doses, even this is this can be tolerated well, even though it is not available in India. So to summarize, in the HER2 positive early breast cancer, fusions less than or equal to 1 centimeter and node negative, upfront surgery can be done. And if it is still stage 1 after operation also, the patient can be given the option of paclitaxel plus trastuzumab according to the APT trial. Whereas in stage 2, 3, and tumors more than 1 centimeter or less than or equal to 2 centimeters, you have the neoadjuvant chemotherapy. If it is node positive, definitely pertuzumab should be added. And if the tumor is more than 2 centimeters, then after the surgery, if there's PAT CR, continue the trastuzumab. And if the patient has no financial issues, pertuzumab can also be continued, but with a caution. And with no PCR, TDM has to be offered to the patient. Thank you.
Thank you, Dr. Surjana. And what is your take on pertuzumab in adjuvant setting? In the site of the latest data, I think affinity
Yes,
trial.
sir. Usually in the adjuvant setting, we don't upfront adjuvant setting. We don't advise for pertuzumab. Patients who do not have PAT CRs, we advise to who are not affordable. Usually, who do not have PAT CR, they can continue pertuzumab. Otherwise, in adjuvant setting, we don't offer, sir.
You don't know.
Yes, sir.
Thank you, Dr. Surjana, for a nice talk. And now I invite Dr. Asim Samar for a Zydus sponsor session, TDM1, where does it stands in 2022? And Dr. Asim is a senior consultant medical oncologist, Rohan Mahavir Cancer Hospital, Jaipur. Boss, over to you, please.
Yeah.
And please try
Thank
to
you.
finish in time, boss, please. Yeah.
100%. I have given 20 minutes, so I will try to finish in 19 minutes.
Yeah.
Thank you, Dr. Tarachand and Zydus for giving me the opportunity and choosing me as a speaker. So let me share my slides. Yeah. So you will move that slide, right? Okay. Can I take my control, right? Gitika or Ankit?
Yes, sir.
Sir, मैंने शायद आपको दे दिया remote control.
Yeah, you can. You just give me the control so that I can finish in time.
Can you please check, sir? I already.
Otherwise, you move the slide then. You are controlling get this screen. Okay. That's nice. Let me do the full screen. Okay, but I want to do a full screen view. Now it is not getting full screen, huh?
So it is full screen only. We
No,
are
but
able
in
to-
my computer it is not full screen. What to do? The letters are so small. Can you do that? The slides are moving, but it's not full screen on my screen. Always it's come like this. Just a minute. Okay, done. But now the slides are not moving. Okay, go to the first slide, please.
So wait, I'll share again.
Just a minute. Okay, go to the first slide. Yeah, so sorry for the interruption. And TDM1, where does it stand in 2022? This topic we'll discuss later. So what is the HER2 targeted therapy and what is the mechanism of action? This cartoon is a little bit important because some students are there. You can see, like in 1998, the first and major discovery against the HER2 positive disease was trastuzumab, anti-HER2 therapy, targeted antibodies. And it has changed all the paradigm, because earlier to this, there was a very dismal prognosis of the HER2 positive disease, and it was almost lethal disease if patient could have this HER2 positive breast cancer. But after the trastuzumab discovery, the prognosis has changed, and it is almost similar if you can target the trastuzumab, target with trastuzumab as the hormone positive disease. So the major breakthrough was the trastuzumab in 1998. Then second therapy in the form of oral TKI has come as a lapatinib in 2007. In 2012, they discovered the anti-HER2 and HER3 therapy, that is pertuzumab, which is the dual blockade. Dual blockade means you can see it inhibits the dimerization of the HER2 and HER3 and inhibits the downstream pathway. So this is again second major discovery. After that, in 2013, TDM1 was discovered and approved for the clinical use. TDM1 has made a greater impact in the patient who had brain mets and failure after the trastuzumab. And after that, we had witnessed in recent year TDXD, which has a very appreciable data and very good data. So you can move the slide. TDM1 as an antibody drug conjugate. Please, next slide. So here I will stay for a few moments. This is a trastuzumab, and which is a well-known drug and causing HER2 blockade. And the drug is designed as a you can see the anti-cytotoxic therapy is linked with this antibody with this linker, which is known as the melamidoethyl cytoxane carboxylate, MCC. This linker has played a very good role because it has attached the cytotoxic chemotherapy, and after this attachment, it is antibody drug conjugate, and it is targeted towards the trastuzumab, towards the HER2 receptor, and it goes to the cell which is having this receptor. So unnecessarily, the drug is not delivered anywhere else other than the HER2 positive cells. So it is a targeted therapy. Cytotoxic therapy is targeted by the target. Right. Next, please. Next slide. Kitika, next. Okay. The linker was shown. Okay. The mechanism of action of this TDM1 is inhibition of the HER2 signaling and ectodominance shedding. So when this antibody, this trastuzumab and this linker and the cytotoxic component of the TDM1 just circulate into the blood and goes to the breast cancer cell, which is HER2 positive, it causes the toxicity by three mechanisms. One is to shed the outside domain of the transmembrane domain of the HER2 receptor. So this becomes like this receptor, and is no more working for the inhibition of the apoptosis of the cell. And other mechanism is ADCC, which is very well known and studied mechanism. When this antibody binds to the HER2 target on the breast cancer cell, it attracts the T immune cell, which is effector cell, and this immune cell causes the destruction of this tumor cell. And the other mechanism is antibody dependent cellular, DM, this you can see derivative of the mitensine mediated microtubule depolymerization. What happens is this antibody drug conjugate is endocytosed by this receptor, is attached to the receptor, and then it is endocytosed. And after endocytosis, this lysosomal degradation of this antibody, and you can see this linker happens, this cleavable linker happens, and this antibody, this drug, cytotoxic drug, released in the cytoplasm of the tumor cell, and then it acts by inhibiting the microtubule, which is the major action of DM molecule. DM is derivative of the mitensine. after inhibition of this microtubule, this catastrophe and apoptosis happens and the tumor cell will killed. Next, please. TDM1 approved indication by 2021. Adjuvant treatment of patient with HER2 positive early breast cancer who have residual invasive disease after neoadjuvant taxane and trastuzumab based treatment. So this was the first approval. And second was HER2 positive metastatic breast cancer who previously received trastuzumab and a taxane separately or in combination. Patient should have either. So it is a second line approval in the metastatic breast cancer who was HER2 positive. So if the patient has received prior therapy for metastatic disease, maybe taxane and trastuzumab, or developed disease recurrence during the or within 6 months of completing adjuvant therapy. So this was the second indication in which it was approved. In India, TDM1 biosimilar got approved in December 2020, and it is available in since June 2021, and all the centers are using it very rampantly. So what are the trials supporting TDM1 use in early breast cancer? Earlier speaker was also discussing this issue. TDM1 was first addressed in the Catherine trial, and second was the ATTEMPT trial. In Catherine trial, it was a response-based adjuvant option. Suppose we have given the chemotherapy plus trastuzumab in the neoadjuvant setting. Patient received full chemotherapy, then surgery was done, and if there is a residual disease in the node or in the tumor, then patient was randomized against the routine trastuzumab maintenance and TDM1. And the data had shown like TDM1 is far better than the trastuzumab. And similarly, ATTEMPT trial was done where the stage 1 patient with upfront surgery and single agent therapy was given. This is the actually chemo de-escalation approach. Next, please. So Catherine trial design and schema is this. It was international randomized open label phase 3 study, and patient the profile was HER2 positive early breast cancer, clinically T1 to T4 disease, N0 to N3, and who had residual invasive disease in breast or axillary node after neoadjuvant chemotherapy plus HER2 targeted therapy at after the surgery. So the patient was randomized within 12 weeks of surgery. Either they got the trastuzumab maintenance 6 mg per kg Q3 weekly into 14 cycles, or TDM1 3.6 mg per kg Q3 weekly into 14 cycles. So almost 743 patients in both the arms. A large chunk of the patient were tested, and the primary endpoint was the invasive disease-free survival, and secondary endpoints were distant recurrent-free survival or OS or safety. Next, please. So this Catherine trial had shown results where the 3 years the IDFS was 83% in the TDM1 arm, and trastuzumab alone arm as a maintenance was 77%. So delta of difference was 11%, and the graph was separated very early. That means this particular drug is effective, and the effect is maintained throughout the testing period and at the follow-up also. So they concluded, author has concluded like there is a 50% reduction in the risk of recurrence because hazard ratio was 0.50, and the p-value was significant 0.0001. So this has made an impact and it was a practice changing trial. Earlier it was not possible in India because Kadcyla was very, very costly. But as the generic drugs are available nowadays in India, we can also modify our adjuvant treatment protocol, and we are modifying it because it's such a you can say low cost therapy now. Next, please. This is the same thing in the other pictorial form. Next, please. Just go to the previous slide. One important fact was there. So they have seen like patient has received trastuzumab in the NACT setting, or sometimes patient may receive like TCHP protocol, this pertuzumab trastuzumab based chemotherapy, dual blockade anti-HER2 neoadjuvant chemotherapy. Still, if you give TDM1, patient got the benefit. That means you do the dual blockade or single blockade in adjuvant setting. If patient has a residual disease, you need to give TDM1. So this TCHP protocol, you can see like the survival is 91.4% if you give the TDM1, and in the single blockade, if you give the TDM1, it was 87.7, and with the comparator arm, it was always you can see it was a significant difference. Hazard ratio was 0.489, hazard ratio for the IDFS. So it was important. and the difference of 11.8 month in the trastuzumab TDM1 Catherine trial and in the patient who had the 10.5 months, 10.5% improvement in the TCHP protocol trial. Adjuvant TDM1 builds on an efficacy gain with pertuzumab trastuzumab in the neoadjuvant setting. Next, please. And you can see this forest plot is shown. It doesn't matter like patient is ERPR negative or ERPR positive, or patient has received a trastuzumab alone or trastuzumab pertuzumab or sometimes lapatinib also, and patient is not negative or not positive. Across all the group, the TDM1 in adjuvant setting has shown the benefit, and all the diamonds are in favor of TDM1 arm. Next, please. Catherine secondary endpoints was distant recurrence. It was still better in the 6.7, but better by 6.7% in the TDM1 arm as compared to the trastuzumab alone arm, and overstayed up to almost 30 months, like 2.5 years. It is the graph for almost same, but you can say like up to 3 years. But after 3 years, the graph are starting separating, and that makes the impact like after 3 years there is a difference between TDM1 arm and trastuzumab arm in the overall survival, and this survival may mitigate because sometimes the crossover was allowed. Next, please. Phase 2 attempt study. This TDM versus TH followed by H. T is paclitaxel. So women with the age stage 1 HER2 positive breast cancer with angular and microscopic disease, LVF 50%, no prior invasive breast cancer surgery, and within 90 days from the last surgery, the patient were randomized in true arm 1:1 fashion. TDM1 3.6 mg per kg into 17 cycles, and Pacli and trastuzumab weekly fashion, and then trastuzumab 3 weekly. So best protocol we know like it should be given weekly, and after that they have continued 3 weekly. Next, please. You can see that by hormone receptor status and tumor size, there was TDM1 has almost, you can see like 97% DFS at the 3 years interval. 3 years DFS is 97%. P value was 0.001. It was important to know that IDFS was very, very good in this 3 years this TDM1 arm. Next, please. In the TH arm, Pacli and trastuzumab arm, up to three years, up to 2.5 years, the graph was very similar to the TDM1 arm, but after that, the graph is slowing down and dropping down. So it has an impact. Like DFS at the 3 years 92 as compared to the 97, so it was significant. Next, please. And usual side effect of the TDM1 was lesser in TDM1 arm. Neuropathy and neutropenia was lesser, 11% versus 24%, 3% versus 13%. Infusion-related reactions are lesser in the TDM1 arm. So study author concluded that TDM1 may offer an alternative treatment to TH in patient with stage 1 HER2 positive breast cancer who have concern about the TH specific toxicity, and shorter duration TDM1 could be evaluated. Next, please. And this is the NCCN guideline, the fresh guideline 2022. If patient is hormone receptor negative, HER2 positive, and has a residual disease, YP T1 to T4 and N0, or YP more than one node, N1 disease. So edotrastuzumab is TD1, TDM1 is category 1 indication. And in HER2 positive disease, if patient has residual disease, also they should be receiving this TDM1. Next, please. Strategy for managing patient with stage 1 to 3 HER2 positive early breast cancer. So in early breast cancer, surgery has been done, and trastuzumab based chemotherapy observation only, TH followed by trastuzumab for 1 year. So you see, you can assess the risk if patient has more than stage 1C. And here, if patient has a T2 disease or more, T1 disease, you can especially offer the trastuzumab, and there is no need for TDM1. But once the disease is T2, means tumor size is more than 2 centimeter or N1 disease, then neoadjuvant therapy is recommended. TCHP protocol or AC followed by THP, like this is taxane, trastuzumab, pertuzumab. Then surgery should be done. And if patient has residual invasive disease, TDM1 should be given for 14 cycle. If patient is achieved PET-CR, there is no residual disease, then trastuzumab should be continued if patient has a more than T2 disease. So next, please. These are the trial for metastatic breast cancer who are HER2 positive. Let me take the time. Amelia trial, standard second line option. There is a trial beyond second line, like third line, the 2 lines of the anti-HER2 therapy, and then third line, Camilla and Amelia subset activity in the patient with CNS mets. Marine trial, first line option for selected patient who had the brain mets, and real world studies. So we'll move fast now. First line, trastuzumab based therapy, TDM1 previously provides superior efficacy relative to the other HER2 based therapies. In second line, Lapatinib versus capecitabine and beyond. Beyond, it's like if you compare with the physician choice treatment. And almost there were, if you do the meta-analysis, it is up to the 5,500 patients data. If the different trial you can add on, then it is more than 5,000 patient data. Next, please. So this was the Amelia trial for the second line option, and Teresa trial was beyond the second line option. Second line means 2 lines were exhausted anti-HER2 therapy. So here the patient has received prior taxane and trastuzumab in the metastatic or locally advanced setting. Then patient were randomized, or they may relapse within the 6 months. Patient were randomized to TDM1 arm versus capecitabine plus lapatinib arm. If patient has progressive disease, they can be taken over to the Teresa trial, which was the third line option. The patient had not received. Next, please. In Amelia study, you can see this median PFS was 6.4 months in the LabCap arm versus the TDM1 arm was 9.6 months, and the p-value was very good, which is superior, and p-value was significant, 0.0001, and the hazard ratio was 0.65. That means 35% patient had received reduction in the PFS free interval, and overall survival was also better in the TDM1 arm. It was 30.9 months versus 25 months in the capecitabine lapatinib arm, and the hazard ratio was significant, as well as the p-value was significant, 0.0006. The 3 months benefit in the PFS and 6 months benefit in the OS. Next, please. These are the toxicities we all know, like TDM1 and LabCap. So diarrhea is more common in the lapatinib and capecitabine arm because both can cause diarrhea. 57% patient, and here is about 40. You can see diarrhea, PP syndrome, vomiting, hypokinesia, and neutropenia. All those aspects, this TDM1 is more safe, but these 3, AST, ALT elevation, and thrombocytopenia, it was more in the TDM1 arm. Next, please. There is a study, this is beyond second line, means 2 line have exhausted anti-HER2 therapy, and then you give the TDM1. The PFS was in the TPC arm, treatment of physician choice arm, it was 3.3 months, whereas in the TDM arm, it was 6.2 months. So the graph was separated very apart, and the separation has maintained till 12 months. And here overall survival is also better in the TDM1 arm as compared to the treatment of physician choice. Median survival was 15.8 months in the TPC arm versus the 22.7 months in the TDM1 arm. So at the crux, 3 month benefit in the PFS and 7 month benefit in the OS. Encouraging activity in patient with CNS metastasis. This is the most popular gain of the TDM1. Like this drug is better in the patient who had the brain mets, and this HER2 positive disease, HER2 positive patient generally have brain mets if they survive longer, or maybe in the baseline also. So in Amelia trial, in an exploratory post hoc analysis of the patient of CNS disease at baseline, TDM prolonged OS is compared to the LAP and CAP. And mind it, lapatinib and capecitabine also can cross the blood-brain barrier, or they are crossing the blood-brain barrier, but their effectivity is more in the TDM1. Hazard ratio was a 0.38. That means almost you can see 62% patient was benefited with the TDM1 arm. And this Camilla trial, progression-free survival in patient and with and without brain mets at baseline.
I request you to conclude your
Yeah,
sentence.
please. I will do that. So Camilla trial is not very great, but it had shown like patient will benefit if they have baseline brain mets or after that. So this graph has shown shrinkage of the brain met size. So you can see like up to 30% patient overall response, the proportion of patient with confirmed response is 21.4 patient who had CR or PR. So decreasing size of the brain mets is also important, and clinical benefit rate was 42.9% with the TDM1. So Marine trial, we can see that, but it's not very great. Marine, we'll skip that trial. So in that, this is the last but one slide. So strategy for managing patient with HER2 positive MBC. Patient may have received pertuzumab, trastuzumab, taxane, or may be maintained on the trastuzumab, taxane after response. A patient had when neoadjuvant setting this kind of drug, and patient has residual disease. The options are TDM1 or TDXD. TDM1 is well studied in the various trial. TDXD is still being under investigation and larger data are required. So these are the options for the adjuvant setting. And after failure of that, the various options are available. Multiple lines of the chemotherapy, maybe tucatinib, trastuzumab, capecitabine combination, or trastuzumab docetaxel, trastuzumab pacli, or carbo, trastuzumab lepatinib, capecitabine, trastuzumab lepatinib. This and other is the margetuximab and chemotherapy. So next. This is the Indian data and perspective where they have given 80 patient of TDM1 and they got the PFS of 10 months and OS is 27 months, and the dose interruption or delay was 31%, which is very striking. But nowadays we know like it is little lesser in our clinical experience. But this is a great data base for the patient who have collected the Dr. Ajay Gogoi. Next, please. So for patient in the India, TDM1 is unmet need, larger number of deserving patient for this drug in India, but access or its biosimilar development was biggest barrier so far. But Zydus has come up with this Indian molecule, generic molecule, and we are getting the results also. Next. These are the phase 3 data. I will skip that. They have compared the biosimilar Ujvira and the Kadcyla, and they have concluded that the results demonstrated the biosimilarity between Ujvira, the Zydus product, and Kadcyla in the patient with HER2 positive metastatic breast cancer with respect to the efficacy, safety, pharmacokinetic, and immunogenicity. So thank you very much. And I have started late, so took 10 minutes more. Thank you very much. Thank you, Dr. Tarachand and Zydus for giving me the opportunity. Thank you once again. And while preparing this talk, I also learned a few concrete things. Thank you very much.
Thank you, Asim boss, for a wonderful talk on TDM1 and explaining the role in early and breast cancer and also the first, second, all the lines. And this is a wonderful molecule. Now we move forward, and for the next is the panel discussion that will be moderated by Vikas Talreja on the management of the HER2 positive metastatic breast cancer. Dr. Vikas is a senior consultant medical oncology, Regency Hospital, Kanpur. His esteemed panelists are Dr. Ankur Punia, Assistant Professor, Department of Medical Oncology, Shri Ram Center, Mahatma Gandhi Medical College, Jaipur. Dr. Rishabh Kothari is a consultant medical oncologist, CanCure Cancer Center, Narayana Multi-Specialty Hospital, Ahmedabad. Currently, he is running his own center, OncoView. Dr. Siddharth Turkar, Director, Radiant Hospital and Cancer Hospital, is not available because of some logistic issues, and I am replacing him. And Dr. Abhishek Singh is a medical oncologist and hematologist, Chandan Cancer Hospital, Lucknow. Dr. Sameer Srirangawal, who is a consultant medical oncology, National Cancer Institute, Nagpur. And Dr. Sunil Chopade, consultant medical oncology, Prince Ali Khan Hospital, Mumbai. So, Dr. Vikas Talreja, please.
Thank you, Dr. Tarachand, for a very kind introduction, and welcome all panelists. Thank you, Dr. Asim sir, for setting up a beautiful platform. I won't be dealing much of the slides right now because we know HER2 metastatic breast cancer has changed a lot during the last many years, and we have esteemed panelists with us. So we'll directly move to the case-based discussions. Metastatic breast cancer, HER2 positive. How many of your patients go directly to chemo? A, B is chemo plus targeted agent trastuzumab. C, chemo plus trastuzumab plus pertuzumab in the first line situations. We'll start with Dr. Ankur.
Yeah, so I will say about 50% of cases go first to chemo because of some of the other things which are beyond our control. I'll say around 50%. And in my practice, almost 95% of patients will receive only trastuzumab, and I will say 5% or even less will receive a combination of front.
So accessibility still remains a very important factor for
Co-
us.
Cost is
5%.
cost is, I think, the biggest issue.
Perfect. Dr. Um, Sameer. Dr. Sameer is
Hello.
Yeah,
Hello.
perfect, sir.
I'm audible?
Yeah, perfect, sir. You're audible.
Mhm.
So
Can you repeat question?
how many of your patients go for chemo plus trastuzumab and chemo plus trastuzumab plus pertuzumab in the first line metastatic breast cancer?
Okay, so I would say less than 5% trastuzumab plus pertuzumab. Around 3 to 5 patients I've treated in the last 6 months. Almost 70 to 80% get trastuzumab. Around 20-30% doesn't get HER2 therapy, only chemotherapy.
Dr. Rishabh, you also will agree with the same figure, or you will have some different figure of yours?
So, as 2 plus per 2, I would agree. It is even less than 5%, means I think mostly it is less than 1% also. For trastuzumab, because of government scheme, we are able to give it to everyone at least for 6 months. And chemotherapy to all eligible patients and trastuzumab to all eligible patients, but for 6 months.
Perfect. And we have Dr. Sunil with us.
Yes, sir. Most of the patients go for chemotherapy plus trastuzumab. Pertuzumab, as all other panelists said, it is less than maybe 2%.
So what are your factors apart from the finances that govern your choice for the first line metastatic breast cancers? We know that Cleopatra has been there, and it has invariably been unmoved for the first line metastatic breast cancers. So do you play an important role that whether the prior trastuzumab was used in the adjuvant situation for discussion about the pertuzumab for first line metastatic breast cancers? Or you think of any visceral disease burden as an important factor, the ERPR status, the Ki-67 status of your patients based on, and the brain metastasis in question for your patients with the first line metastatic breast cancers. So, Dr. Ankur?
Yeah, for a patient, apart from cost, the thing what matters, what I think of is patient who has received trastuzumab, in the adjuvant setting, and they progress within 6 to almost 12 months. In those patients, I don't think there will be much use of giving a pertuzumab or trastuzumab combination for those patients. Yes, a patient who has progressed after 2, 3 or many years, then yes, definitely I would prefer it. But not for a patient who progressed within an year. I think for those patients, rather going for TDM1 would be a much better option, but viable option for these patients.
Dr. Sameer, what factors do you play a very important role that, yes, these are the factors I keep into account for addition of an extra benefit of pertuzumab in the first line MBC situation?
Hello.
Yes, sir. Yes, sir.
Hello. Sorry, because your voice was not audible to me.
So what are the factors that play important role for you for first line putting the patients to addition of the pertuzumab? So whether the prior use of trastuzumab, how much was the disease burden, what was the Ki-67, what was the ERPR status, any of these factors you play a very important role that yes, you need pertuzumab in first line MBC situation?
So I think the data is for triple positive also, and even only HER2 positive also. And in both the setting, it has shown benefit. I don't think any means like patient related factor there that makes any difference. every patient should get pertuzumab if they are affording. So cost is the only issue. Otherwise, I think each and every patient should get if cost is not a constraint.
Perfect. And Dr. Rishabh, do you think any patient you can avoid using pertuzumab in the first line situation, and you can get away with a chemo plus trastuzumab and reserve pertuzumab for a later line of therapy?
No, we will not preserve it for the later line of therapy. For all affordable patients, we will try to give it in first line because we don't know with which other drug we can combine it. And I don't think it is a good idea to preserve it. Only situation is where suppose someone has progressed within 3 months of trastuzumab or something like that, where I would think to give trastu pertu versus TDM1. I would rather go for TDM1 in that situation. Rest all of the patient I would try to give pertuzumab in first line.
So because there is a data for hormone plus trastuzumab and pertuzumab also, hormone therapy for triple positive. So in that case, you can get away with chemotherapy and only give hormone and targeted therapy.
Perfect. Dr. Sunil, you also will agree with the panelists of the opinion that all patients should receive trastuzumab, pertuzumab?
I do agree with Rishabh sir and Samir sir. Every patient should get a chance for pertuzumab. Only in case where a patient has progressed within 3 months of completion of adjuvant treatment, there we will have to think of second line treatment.
So now the major question comes that we have exhausted the chemo, trastuzumab, pertuzumab option in the first line, and the patient invariably progresses in the brain. Now, patient has received brain radiation. What would you think would be the best option for the forthcoming age? It's only an oligo brain progression. So first option is continuing chemo plus trastuzumab plus pertuzumab plus radiation. Second option is putting up to TDM1. Third option is capecitabine, lapatinib in the second line. Cost being not a constraint for him, the patient has already taken chemo plus trastuzumab plus pertuzumab. Dr. Anko?
So patient, just progressing in brain, we can have both the option. We can do, local RT, SBRT. These are oligometastatic in a single or 2-3 lesions, which can be controlled. Then there is an option. We can continue just trastuzumab, pertuzumab, and just get away with SBRT for brain mets. But we have to closely follow up for that brain disease as well, because HER2 patients are prone to get, susceptible to get further brain disease. So they should be regularly followed up. If we are just pursuing the idea of continuing trastuzumab, pertuzumab, and if patient doesn't want, then TDM1 would be the best option.
Dr. Samir, you would also agree with the same, or you have a difference of opinion? Dr. Samir, the patient has progressed on chemo plus trastuzumab plus pertuzumab only in brain. So local control plus continuation.
Hello. Hello.
Dr.
Hello.
Dr. Samir?
Samir's connection is unstable, I think. Samir?
Hello, am I audible? Yeah, am I audible?
Yes.
Hello. Hello.
Yes, you are audible, Samir.
You're audible now. Hello.
Yes.
So patient has progressed with brain mets only, na? And she was on trastuzumab plus pertuzumab. And after how many any details of how many months she has progressed? Hello. Hello.
Vikas, you are muted.
So sorry, I was on mute.
Yeah.
So
hello.
Patient has progressed after, let's say, 8 months. 8 months of therapy.
8 months of therapy. So if the rest of the diseases are very well controlled, I would try to give the benefit to the patient by giving the radiation to the brain and continue the same. And if there is any that is a rapid progression, like patient has progressed within 3-4 months of therapy only. That means there is no response only. So in that case, I may change. If there was intervening SAN which suggested the patient is responding, and only the brain is progressing, then in that case, I would give radiation to the brain and continue with the first line therapy and would reserve the next therapy for next progression. Hello?
You're audible, sir. You're audible, sir.
Yeah. So you got my point, no? Hello? Hello?
Okay. The question goes to Rishabh sir also. Do you also agree
So
that
I would agree to continue same systemic therapy if patient is having single brain mets, which is radiated.
Dr. Sunil?
Yes, I do agree, sir, to continue same therapy and offering local therapy to oligometastatic brain disease.
now the comes between TDM1 and capecitabine lapatinib, what is your second choice? Sorry. Between capecitabine, lapatinib, and trastuzumab TDM1, what is your second choice of the therapy post? Now the progression post 2 months is systemic. There are new liver mets. There is frank progression. So your choice of therapy between the two options. Dr. Ankur?
TDM1 has definitely shown better result irrespective of what kind of progression we get. So if possible, I will prefer TDM1 over LabCap.
And you believe that Roche and Zydus perform the similar way?
Yeah, I've seen good results. I've not that much experience, but whatever limited experience I have with the biosimilar, it has shown good results.
Dr. Samir, what factors, especially in terms of the tox Ts, you think the TDM1 has a score over as compared to the capecitabine and lapatinib, especially in the second line metastatic breast cancers post chemo trastuzumab pertuzumab progression? Dr. Samir, if it's not there, Dr. Rishabh?
So both have a different toxicity profile. For Cape-Lab, diarrhea and hand-foot syndrome is something which is worrisome, especially when you give more number of cycles. So TDM1 would be preferred over Cape-Lab whenever feasible, both from efficacy point of view and even toxicity point of view.
Because you are not audible.
Dr. Sunil, do you also agree that
Yes,
you would
in
prefer
terms,
TDM1 as compared to the CAP-LAB combination in second line situation?
yes, I would prefer TDM1 compared to Kepler. Toxicity wise, as Rishabh sir has pointed out, diarrhea and HFS is quite cumbersome. Also, this skin toxicity with lapatinib in Kepler. With TDM1, it is thrombocytopenia or sort of myelosuppression and liver enzyme elevation, which is there.
Hello?
Hello. Yes, yes.
Hello?
Especially in the second line, whether there is a change in the HER2 status, or you agree with it that it is the biology of the HER2 nature. So how many of you do a re-biopsy at progression? Dr. Ankur?
So patient can lose a HER2 therapy, HER2 receptor on progression, but we clearly don't know whether we can change the therapy based on that. We don't have that much evidence that we can, change the therapy, because even without that, patient has shown to have some response is there, and it's usually more with the antibody drug conjugates. So I would not prefer to change just therapy just because HER2 has been lost, because we don't have enough evidence to change therapy just on that. I will not particularly do a biopsy just to change a treatment.
Yes, Vikas, you are muted again.
I think there's a connectivity issues at his end. Hello? Yeah, Vikas, sir, we cannot hear you.
So Dr.
You are
Rishabh,
muted.
Dr. Rishabh, do you also agree that we
I also
you don't rebiopsy at progression?
Rebiopsy at progression to decide on HER2 directed therapy, I generally don't do it in practice unless it is clinically not congruent. Someone with HER2 positive disease and has progressed in first or two cycle of trastuzumab, it is more to confirm that HER2 report is appropriate rather than to know whether it has changed from positive to negative. Because disease being heterogeneous, even if we get a tissue which is HER2 negative, there can be other sites where HER2 is positive. So it is prudent to continue HER2 directed therapy, irrespective HER2 status at progression.
And I think Dr. Sunil will also agree with the same point of view.
Yes, sir. I do agree.
So in view of shortage of time right now, we know that HER2 new MBC has changed a lot, and with the introduction of the Zydus trastuzumab DDM1, we have a lot of options. And yes, long way, and HER2 new MBC in the near future. I thank Dr. Tarachand for a beautiful crafted agenda, and I thank the whole panelists and the organizers for the same.
Thanks,
I
Vikas.
conclude
And
the panel discussion, and I welcome if any questions are there for now.
thanks, Vikas, and all the panelists, Rishabh, Ankur, Abhishek, Samir, and Sunil,
Hello.
for the wonderful discussion and the participation. And now we are moving for the next topic, that is the management of HER2 positive metastatic breast. Next is the management of HER2 positive, hormone receptor positive, HER2 negative breast cancer. This session is sponsored by Novartis, and Dr. B.S. Ankit Mehra, who is a consultant medical oncologist at HCG Hospital, Jaipur, will be speaking on getting real with ribociclib, bridging the RCT and RWE universe with evidence across 8,000 patients. And I expect Ankit to finish in time. Please, Ankit. Yes.
Yeah, thank you, sir. Am I audible? Can I share my slides from here? So are my slides visible?
Yes, sir.
Thank you so much, Tarajan sir and Novartis, for giving me this opportunity. And unfortunately, due to the lack of electricity in the center of Jaipur, the video will be like quite less bright. So getting real with the ribociclib, I'll be discussing about the real world evidence and comparing it with the randomized controlled trial about almost 8,000 patients. So this is my disclaimer. And if we talk about when we are considering treatment about advanced or metastatic breast cancer, we talk about either a quality of life or a PFS, or basically most common, which is most accepted, is like overall survival benefit. And if we treat an advanced breast cancer who is hormone positive, the NCCN guideline recommends that CDK4/6 inhibitor along with the endocrine therapy should be a category 1 indication. If we talk about a CDK4/6 inhibitors, there are 3 CDK4/6 inhibitors that are there, be it palbociclib, ribociclib, abemaciclib. And if we really talk about the significant OS benefit, the ribociclib across all the first line and second line and premenopausal and postmenopausal, be it MONALEESA 2, MONALEESA 3, and MONALEESA 7, has shown an overall survival benefit. Palbociclib has failed to show the OS benefit in PALOMA 2 and PALOMA 3, and abemaciclib, MONARCH 2 has already shown second line as well as a first line, along with the fulvestrant in the first line setting. OS benefit in MONARCH 3 is still awaited, but as we see, either ribociclib or abemaciclib is showing the OS benefit till date as we speak about the CDK4/6 inhibitors. And what is the OS median overall survival benefit? It is just between 10 months to 15 months. So we can say like it is around 1 year of overall survival benefit if we compare about between endocrine therapy along with the ribociclib with endocrine therapy. Coming to the real world experience, except that real randomized control data. So there are two trials. Complement trial is there, which is an international study which compared ribociclib along with the letrozole in the first line setting who were hormone positive advanced breast cancer, and there were more than 3,000 patients. And the second is still ongoing German trial, which is comparing between ribociclib with endocrine therapy versus endocrine therapy alone versus chemotherapy as a first line therapy in hormone positive advanced breast cancer. The target of the trial is more than 3,000, but already 2,500, more than 25% patients, 2,500 patients are included. So coming back to the complement trial, which is a first released real world experience of ribociclib, more than 3,000 patients were there. More than 100 patients were there who were having a performance status of 2. Around 200 patients received already prior chemotherapy, and there were 50 patients who were already having a cranial metastasis. So if you talk about the safety profile, it was quite predictable, manageable, and it was just similar as well the randomized control phase 3 trials was there. Serious adverse events was only 5%. And if we talk about the fatal SAEs, it was only 4%, and the neutropenia, ALT, AST increase in the QT prolongation, which was again same as expected with the randomized control trial. So time to progression with the complement trial was 27 months. If we talk about the median progression-free survival, it was 26 months, and PFS at 1 year was 75, 2 year it was 54, and 33 months it was 40%. And if you talk about the overall response rate, it was 30% in the overall population, and it was around 45% in the measurable, the patient who was having a measurable disease. This slide I really want to talk about the patient who are having a CNS metastasis. So abemaciclib had a preclinical data were showing that abemaciclib is crossing the blood-brain barrier in the mice, and with that they they had a phase 2 trial which was quite disappointing, and the overall response rate in intracranial mets was only 6%. If we talk about the randomized control trials, there were almost every trial, be it a PALOMA, be it a MONARCH, be it a MONALEESA, everybody excluded those patients. But if you talk about seriously about real world experience with the complement trial, so there were 51 patients, and if you see the overall response rate, be it as an overall population or comparing with the CNS metastasis, the progression-free survival was 27 months versus not reached. Not reached is like, obviously there were only 51 patients, but we can get an idea that both of the subgroups are almost having the same response rates. And if you talk about the patient who had a prior chemotherapy, or the patient who had a performance status of two or more, or again, there is a good separation of the graph. And if you talk about the outcome of the patient in terms of quality of life, be it is a physical well-being, social, emotional, functional well-being, it was quite the same at the start of the treatment and at the end of the treatment. The second trial, which is still ongoing, is still comparing between ribociclib with endocrine monotherapy versus endocrine therapy versus endocrine monotherapy versus chemotherapy. Median age group is same, around 70 years. Postmenopausal patients are same, around 90%, and premenopausal around 10%. Still, two or more than two performance status patients are there, more than 50% of the patient, which is quite we are expecting that what the actual data will come, and almost 50% of the more than 50% patient were either having a CNS, liver, lung, bone, or skin metastasis. And still the data is not out, so unadjusted PFS is between ribo with AI or ET is 37 months versus ET alone is 25 months, and with chemotherapy alone is 15 months. And again, the safety profile is quite similar. Grade 3, grade 4 adverse event is almost less than 2%. And if you talk about the outcomes of PFS in the randomized controlled trial, which was between 25 to 35 months, it was quite the same, between 26 to 37 months. Although serious AIs and the discontinuation rate was 12% complement of the randomized control trial, but still Ribana trial is awaited. We have to see and wait and watch what the Ribana trial will have to talk about the discontinuation rate due to the AIs, and everybody knows about the first line indication about the either be it as a NCCN, ESMO, or ESCO guidelines. Yes, are there CDK4/6 inhibitors? All three are different. Yes, they are. As few, if you talk about CDK4/6, so CDK4 targets is more being with the ribociclib. CDK4 and 6 is equally targetable with the palbociclib, and the off-targeted actions with the abemaciclib is as high as 52, which is again giving some adverse events like diarrhea or thromboembolization. So concluding my slides, early uses of CDK4/6 inhibitors is an category 1 indication per NCCN and as well every guidelines. The longest OS has been yet achieved is 63 months with the MONALEESA-2 trial. Improvement of OS with the ribociclib, be it as a endocrine partner or ribociclib, it is across all the therapies, and there was similar efficacy in the randomized and the real world experience. And there was in the real world experience, be it as a CNS metastasis, visceral, or pre-chemo treated patients, or the patient who are having a performance status by the 2 or more than 2, was equal. And yes, off-targeted inhibitions with the ribociclib is quite less. And I would thank again and Tarachan sir.
Thank you, Ankit. You are always ready to participate and to give your support these talks in our sessions, and you are really have a depth and depth knowledge of. Especially, I think I have seen many patients admiring you for the at least the breast cancer. Yeah, that was a nice talk by you. And now I invite Dr. Sandeep Berwa. First of all, I welcome Dr. Sandeep Berwa in Jaipur again. And he's now as an assistant professor in NIMS Hospital, Jaipur. He will be talking on the Pfizer-sponsored session, deciphering the overall survival data of PALOMA-2.
Thank you, sir. Thank you, Tarachan, sir. Let me share my slides. Are my slides are visible?
Yes, sir.
Okay. So I will discuss about the Paloma trial. I will now discuss the Paloma 2 study design. This was a randomized trial, and the inclusion criteria for patients was the postmenopausal women with ER positivity and HER2 negativity, having advanced breast cancer. No prior treatment for advanced diseases were allowed. Included patients were having a PS of in between 0 to 2. Total 666 patients were screened, and they were randomized in a 2:1 fashion between the experimental arm of palbociclib 125 mg per day, 3 weeks on, 1 week off, in combination with the letrozole, and the standard arm was placebo plus letrozole. The primary endpoint was the investigator assessed progression-free survival, and the secondary endpoints were the overall survival, response rates, safety. The stratification factors were used are the disease sites, visceral or non-visceral. Patients were stratified according to disease-free survival, disease-free interval, whether it is a de novo metastatic disease or the disease-free interval is less than or equal to 12 months or the more than 12 months from the completion of therapy. Prior neoadjuvant therapy or prior neoadjuvant hormonal therapy was also used as a stratification factor. So the statistics used was to calculate the sample size. It was used to determine the detect the improvement of 44% in median progression-free survival from 9 months from the control arm to 13 months in the palbociclib arm. Assuming a hazard ratio of 0.69 in favor of palbociclib, the sample size calculated was the 666. Statistical assumptions for overall survival as a secondary endpoint used was the assumption for the control arm median overall survival of improvement in median overall survival of from 34 months to 46 months. So a 35% improvement was expected. 390 events required to detect a hazard ratio of 0.74 or less with 88% power and with one-sided alpha of 0.025. So what was the endpoint? The primary endpoint was the progression-free survival, and the median PFS in the experimental arm of palbociclib plus letrozole was 24.8 months, and in the standard arm with the letrozole alone, letrozole plus placebo arm was 14.5 months. And in the updated analysis, the progression-free survival raised up to the 27.6 months in the palbociclib plus letrozole combination, and it was 14.5 months with placebo plus letrozole arm. So the baseline characteristics in between the two arms, the median age was 62 in both the arms. Most of the patients were belonging to ECOG PS 0 to 1, and disease sites, visceral and non-visceral patients were equally distributed among two arms. Disease pre-interval less than 12 months from the end of adjuvant to the recurrence was also equally distributed in the two arms. It was 22%. Prior endocrine therapy, 56% of patients has received prior endocrine therapy in both the arms. So patients were randomized in a 2:1 fashion. 444 patients have received the experimental arm. Among them, 62% patients ultimately succumbed because of the disease, and 25% patients remained alive. The 59 patients, the survival data were missing, and it constitutes 13% of patients. In the standard arm, 132 patients succumbed, 19% patients remained alive, and the missing data about survival was not available in 47 patients. So around 21% of patients. This is because of the 66% patients who had withdrawn their consent, and 34% patients were lost to follow-up. In the experimental arm, 10% of patients were still on the treatment even after completion of the trial. And in the overall survival analysis, according to intention to treat, the median overall survival was 54 months in the experimental arm, and it was 51 months in the standard arm. The stratified hazard ratio was 0.956. The curve was very close to each other. Overall survival in subgroup analysis, as we can see in this forest plot, patients with ECOG performance status of 0. This group has the maximum disproportionate mixing data between two arms of letrozole and the experimental arm of palbociclib plus letrozole. Only in this subgroup, there is major difference between the overall survival. Otherwise, in all the subgroups, whether the patient is having visceral disease or having non-visceral disease, whether patient is having de novo metastatic disease, or a patient having a disease-free interval of 12 months or more than 12 months, patient has received prior endocrine therapy, or patient is having bone-only disease. In all these subgroups, patients randomized to Palbase plus letrozole arm, that arm did well. The results were in favor of combination of palbociclib plus letrozole. And in the post-hoc sensitivity analysis, excluding the patient's fair survival data was not available. There was a significant difference in overall survival between the two arms. So it has become 51.6 months in the experimental arm of palbociclib plus letrozole, and it was 44.6 months only in the placebo plus letrozole arm, and it was statistically significant with the hazard ratio of 0.86. Further numerical overall survival improvement favoring palbociclib combination therapy, indicating the impact of missing data, is seen in this graph. And when I combine the Palomar 1 and Palomar 2 to calculate the combined overall survival, the median overall survival in the experimental arm is 51.52 months, and in the control arm it is 47 months with a hazard ratio of 0.93. And in patient subgroup where the disease-free interval is more than 12 months, the experimental arm has a median overall survival of 64 months, which is far better than the control arm, having a median overall survival of 44.6 months, with the hazard ratio of 0.773, which is statistically significant. So what post-study systemic therapy were given? Patient who has progressed or has discontinued the study treatment has subsequently received either endocrine therapy or chemotherapy or CDK4/6 inhibitor. The predominant endocrine therapy was fulvestrant or exemestane. The predominant chemotherapy used was the capecitabine and taxanes. Some patients has received subsequently palbociclib, abemaciclib, or one patient has received ribociclib in both the arms. And what about the time to further chemotherapy initiation? So this time for initiation of second subsequent chemotherapy is significantly delayed in the experimental arm of palbociclib plus letrozole. It was 38 months, and it was 30 months in the standard arm of placebo plus letrozole. It was statistically significant with the hazard ratio of 0.73. So this table is showing first line use of 3 CDK4/6 inhibitor in postmenopausal women with the hormone positive and HER2 negative advanced breast cancer. Paloma 2 using palbociclib, Monarch 3 using ribociclib, and Mona Lisa using abemaciclib. So in a gross comparison, Paloma 2, it was a phase 3 2:1 randomized double-blind placebo-controlled study done among the postmenopausal women with ER positive and HER2 negativity. Patients with the performance status of 0 to 1 and visceral and visceral diseases were included. These patients can have received the prior endocrine therapy. In Monarch 3 was also a phase 3 2:1 randomized double-blind placebo-controlled study. In this study, across these studies, the included patients were having a performance status of 0 to 1 predominantly. Across these studies, the number of organ involved were similar, and the number of patients receiving or not receiving prior endocrine therapy were also similar across all these 3 studies. The difference is in Paloma 2, the patients having a disease-free interval of less than 12 months from the last completion of therapy, meaning patients who are endocrine resistant, were 22% in the Paloma 2 study. And these relatively endocrine resistant patients were not included in the Monarch 3. And vis-a-vis in Mona Lisa trial, there was only one patient having a disease-free interval of less than 12 months. That means a significant proportion of patients, almost 22% of patients, were having endocrine resistant in the Paloma 2 trial. So that means a significant proportion of patients were having high-risk disease in the Paloma 2 in compared to Monarch 3 and Mona Lisa trial. So again, showing the same difference in the endocrine sensitive population. So in the Paloma 2, patients having disease-free interval of less than 12 months were constituting a 22% of patient population. It was 1% in the Mona Lisa 2, and it was 7% in the Mona Lisa 7, and it was 0% in the Mona Lisa 3. These Mona Lisa trial have used abemaciclib based hormonal combinations for the treatment of advanced breast cancer malignancy. In Monarch 3, endocrine resistant populations were excluded. Simultaneously, disease-free interval of more than 12 months, 40% of patients belong to this category in the Paloma 2, and 60 to 80% patients belongs to endocrine sensitive category in the Monarch 3 and Mona Lisa trials. So bottom line, more endocrine sensitive patients, more than 50%, was in the Mona Lisa trial, and endocrine sensitive subgroup is driving survival benefit in the Paloma 2, Mona Lisa 2, 7, and 3. Now the effect of palbociclib in the endocrine resistant patients. So PFS benefit in between patients having disease interval of less than 12 months or more than 12 months is similar and significant in the Paloma trial. So whether patient is having a disease interval of less than 12 months or more than 12 months, this forest plot is showing that these both subgroups are benefiting with the addition of palbociclib. OS difference is affected by the disproportionate missing survival data in the Paloma trial. So as I said previously, in the Paloma trial, the combination arm of palbociclib plus letrozole, 12% was patients were having 12% patients in group of patients where disease interval was less than 12 months were having a missing data, and in the placebo plus letrozole arm, this missing data was in the 29% of patients. In group of disease interval of more than 12 months, this missing data was 17% in the experimental arm, and it was 15 months in the placebo arm. So total 10% difference, 10% patients were having a missing data in the experimental arm, and total 24% were having missing data in the placebo arm. And what is an acceptable loss to follow up a missing survival data in clinical trials? In randomized controlled trials, typically investigating drugs or other therapies, it has been suggested that a loss to follow up of more than 20% poses a serious threat to the validity of the data, and even 10% loss may pose biases in the statistical analysis. Palomar 2 had a disproportionate loss to follow up missing survival data between the palbociclib treatment arm and in the control arm. It was 13% versus 21%. That this lack of information about the survival data may be contributing for the equal median survival in both the groups. So now talking about the adverse effect. So most common all causality adverse effect of more than 20%. In the experimental arm, it was predominantly neutropenia. Any grade neutropenia was seen in 22% of patients, and leukopenia was seen in 43% of patients. Grade 3 leukopenia was seen in 26% of patients in the experimental arm, and it was not seen in the standard arm. Other significant adverse effects seen were arthralgia, fatigue, and nausea, which were quite manageable. So in conclusion, Palomar 2 met its primary endpoint of improving progression-free survival and other secondary endpoints. The overall response rate of 55% of combination with palbociclib plus letrozole versus a response rate of 44% in placebo plus letrozole, with the odds ratio of 1.55 in the patients with measurable disease. The safety profile of Palbase plus letrozole remain consistent with long-term use without evidence of cumulative toxicity. Quality of life patients was maintained in the experimental arm. Time to initiation of therapy was significantly delayed in the experimental arm. The OS was numerically higher in the palbociclib plus letrozole combination versus the placebo plus letrozole combination, but the results were not statistically significant. This is because of the lack of information about the missing information about the in both the arms. Median survival of over 50 months in this population represent a significant improvement in the natural history of hormone receptor positive breast cancer patients. And this is highlighted in the subgroup of patients with disease-free interval of more than 12 months. In this subgroup, the median overall survival was reaching up to 66 months. And 10% of patients continue to be on the palbociclib plus letrozole arm even after 7.5 years of follow-up. So interpretation of overall survival in Palomar 2 is limited by the large and disproportionate percentage of patients with missing survival data between the treatment arms. God knows if we have this information, what is the difference in between the overall survival of two arms. Thank you.
Thank you, sir. Thank you so much. Yes, I think Dr. Amit has joined. So I would like to invite Dr. Amit for his talk. And Dr. Amit is Senior Consultant Medical and Hemato-Oncologist at Cancer Institute, Patna. And he is going to speak on integrating immunotherapy into the treatment landscape for patients with TNBC. Over to you, sir.
Yeah, good evening, everyone. I thank Dr. Tarachand for this opportunity. So, in continuation of the today's discussion, I've been given the task about immunotherapy and TNBC. So earlier, as we know that immunotherapy has got a very limited role in this, but now it has been taken care not only in advanced cases, but also in the neoadjuvant setting. So I'll just give you a brief glimpse how in clinical practice we are using this immunotherapy. So how does it works basically? So the TNBC is different from other tumors of the breast in terms of the tumor infiltrating lymphocytes. It has got that higher number as compared to the other subtypes. The PDL1 expression is somewhat higher than other non-TNBC cells. And apart from that, there is a non-synonymous other mutations, or if we say single nucleotide variations per exome. This is also higher in the case of the TNBC as compared to the other. So there are few trials in which the advanced stage of immune checkpoint inhibitors has been used in the advanced stage of this TNBC. So with a modest response. So what we say the response is something around 18 to 20% in different studies, especially in those of the pembrolizumab study or in the Atizo study, it is only around 10%. Avelumab further lower is 5.2. Further, it depends on in which line it is being used, whether it's the first line or it is in the second line. So if it is used in the first line, the response is slightly better as compared to the second line or in the later lines of the therapies. So what we have seen is that a patient with Atizo or Pembro monotherapy, if it has got a durable response, if that is undergoes CR or PR, in that case, the overall survival rate is much higher as compared to they have got a stable disease, or if in the worst, in the case of a progression on these therapies. So the median overall survival, somehow it may go to 8.9 months in the cases with the pembrolizumab in the first line, if in the metastatic may go up to 18 months, which is comparable with those of the chemotherapies. So what we are seeing is that the response to this immunotherapy basically depends upon in which line of therapy it is used, whether it's the first line or the second line, the response varies with that, depending on the tumor infiltrating lymphocyte percentage. So how much is that? That also affects the response. And further, if both TIL, the line and the PDL1, if all are found to be positive, the response is much higher as compared to if these are negative. So the keynote 119 basically shows an association between the PDL1 CPS score and its OS with pembrolizumab. So what we have seen, especially in the intention to treat population, there is not much so difference. But if the PDL1 CPS is more than 20, so this is the hazard rate is something around 0.58 in this group of patients. And even if more than 10 CPS, the hazard rate is 0.78. So this is the condition in which the pembro is found to be effective in the case of the metastatic setting. Further, in the cases of its association between tumor mutation burden and the clinical outcomes, let me say. So if the tumor mutation burden is more than 10 as compared to if it is less than 10, in that case, there is a trend towards improvement in overall response rate and overall survival. So, but it is seen that only minority of the patients has a tumor mutation burden more than 10 mutation per megabase, that is around 10% of the patients have this. But if they have got, there is surely an effect of the immunotherapy in this group of patients. So this cancer immunity cycle basically has got multiple phases. It affects the release of the cancer cell antigen, its presentation, further priming activation, and further the diffusion of cytotoxic T lymphocytes, resulting in the infiltration of the T cell into the tumor cells, or further recognition of these cancer cells, and finally the killing of the cancer. So there are now multiple pathways involved, and on this the PD-1 PD-L1 inhibitor is one in association with chemotherapy, PARP inhibitors, AKT inhibitors, and further MEK inhibitors and others coming in this picture. The next study was IMpassion 130. As all you know that Atizo when add to the first line nab-paclitaxel in advanced TNBC, it has been shown that with the pre-specified PFS and OS as the setting. In this study, they have either taken prior patients who have at least more than 12 months of disease-free interval. So the thing is important in that in this group, if we see that in the intention to treat population also shows the hazard rate of 0.8 in this, whereas the PDL1 positive patient is showing a hazard rate of 0.63. So there is a much higher where benefit in the PD-L1, but all patients are found to be benefiting in this group. So the overall survival, if you see by the PD-L1 IC immune cells status, it is something around 25 months as compared to those of the placebo, which is 18 months. So the median OS is drastically improving in the PD-L1 patient, whereas in the PD-L1 negative patient is more or less same in both the groups. So if the patient is PD-L1 positive, so atezolizumab has nab-paclitaxel has got a better benefit. So this final OS is basically analysis also showing the same thing, that the median OS is something around 25.4 as compared to 17.9 months in this group. And if we take a 3-year overall survival, there is a clear 14% difference in both of these groups. But when the paclitaxel was added to atezo and the other IMPassion 131 study was done, in the similar setting when which paclitaxel was used, the benefit which was seen earlier was not present in this. The PFS, though there is a PFS benefit, there is no OS benefit in this, though the PFS shows a hazard rate of 0.82 in this group of patients. So if we see the updated interim OS overall survival analysis is in the case of the PD-L1 positive patient with 131, what we see is the hazard rate is something around 1.55 in this group of patients, and in the intention to treat is 1.31. So it is the OS is found not to be effective in the case of the addition of paclitaxel. But pembrolizumab was when used in the case of the first-line chemotherapy in advanced TNBC. And in this group, what they have done, they have not only used nab-paclitaxel or paclitaxel, but gemcarbo has also been used. And the duration of therapy is, they have taken part in the earlier trials, it is 1 month, 1 year post progression on the earlier treatment. They have decreased the duration to around 6 months before the first treatments they have taken in this trial. And in this group, what we see, the median PFS on the pembro group is something around 7.5 months as compared to the placebo group, which was 5.6 months. So there is a definite benefit of addition of immunotherapy in the pembro to the chemotherapy regime. And if we take the CPS more than 10 population, this benefit further increases to 9.7 months in comparison to the placebo group, which is 5.6 months. So, and if we see across all the subgroup analysis which has been done, so in almost every subgroup, whether the performance status or the site, the only thing is gemcarbo group has not shown so a great benefit as compared to nab-paclitaxel or paclitaxel, but still one may say that gemcarbo has to have got a benefit. So if you are using it after 6 months, so these patients are also responding in this group. So the Keynote 355 clearly shows that if we see the PD-L1 CPS more than 10, there is a definite benefit across the nab-paclitaxel, and also the gemcarbo also showing a favorable in this group. It is also being seen in, if we say is CPS more than 1, or if the intention to treat population. So almost all the groups, whether it is if you are based on the CPS or also in the intention to treat, have shown a benefit with this. Regarding adverse event, it is more or less similar to all other earlier immunotherapy related trials with hypothyroid, as we know the endocrine manifestations being more common in this group of patients, apart from few patients as having pneumonitis and colitis, but others are being rare. So one thing what we see in the PD-L1 is scoring, so how it is being done. So it is basically the CPS, TPS or the IC. So it is basically the companion diagnostic has to be taken care of before giving any immunotherapy to these group of patients. So CPS basically, which includes all the tumor cells, lymphocytes and macrophages, and it is divided by the viable tumor cells in this group of patients. Whereas the TPS includes only the tumor cell stainings, as we say, divided by the viable tumor cells. Whereas the immune score or the immune cells simply includes only lymphocytes and macrophages without any tumor cells by the tumor area. Basically, the immune cells area, it is based on the tumor area rather than on the number or percentage of the tumor cells, the percentage of the area which is being involved in this group. So in the case of advanced TNBC, what we may say is that response, if we are using in the metastatic as a monotherapy, there's only a modest benefit, though it may be affected by the line of therapy, PD-L1 expression level, or tumor infiltrating lymphocytes, and TMB are the factors which affects it. Atezo plus nab-paclitaxel, as you already know, was first approved in the case of advanced TNBC, but later on it has been withdrawn by the FDA, but still the European guidelines still has an approval with them with Atezo plus nab-paclitaxel, though with paclitaxel backbone it is not efficacious. For Pembro plus nab-paclitaxel or Pacli or Gemcarbo, it has been approved as a first-line therapy in PD-L1 positive cases, and it is the, as we say, the different platforms which you are using. It's a companion diagnostics which you have to use, especially in the PDL CPS more than 10. That group you can surely going to use that. There are few unanswered questions regarding how would you say the sequencing has to be done in the case of the metastatic setting, and the combination of them either with the PARP inhibitor or AKT inhibitors. So there is some further studies being needed in this group. The recent changes, what has occurred in the last 1 year is especially in the field of early stage TNBC. So in the case of that, what we say is how is the early stage TNBC different from those of the metastatic, and how does this, what is the therapeutic options? As we know, in the neoadjuvant chemotherapy, downstage the tumor, allow additional time for if you want to do a germline mutation testing or other set increases. Further, if we increase the PCR in this group of patients, we see there is an improvement, though it may not be always, but surely the PCR is a surrogate for all other improved parameters. So other drugs like platinum or sacituzumab has been used, and now checkpoint inhibitors is coming. And if there is a residual disease, so now we have got data regarding the Createx which shows that given capecitabine, and now olaparib is also being used in the case of the advanced residual disease if present with the BRCA mutations in this group of patients. So if we say if there is a patient is having a PACR, they have got the highest survival, and those with a residual disease has got the worst one. So in the early stage tumor as compared to the metastatic breast cancer, if we say chemotherapy is a rational partner for immunotherapy as it disrupts the tumor architecture, results in antigen shedding, and induces the rapid disease control. So chemotherapy addition acts on these ways. And how does early breast cancer differs from the metastatic one? So as we say, the antigen presentation is higher in the case of early breast cancer as compared to the metastatic one. The tumor clonality is less as compared to the metastatic setting. The intratumor heterogeneity is also less, whereas the other markers like tumor infiltrating lymphocytes, CD8 plus T cells, or dendritic cells are higher in this group of patients. Along with PD-L1 positivity rate is higher in early breast cancer as compared to the metastatic one, and further interferon signaling and chemotherapy. So all these biological properties makes the early breast cancer an attractive target for the immunotherapy. So the initial study is about the neoadjuvant pembro or placebo plus chemotherapy. And in this, what it has been done, that is also an adjuvant setting. The pembrolizumab has been given for around 9 cycles in this group of patients. So it is basically all the patients aged more than 18 years and whose diagnosis T1C, N1, N2, or T2 to T4 without any nodes can also be taken in this study. With the initial chemotherapy as paclitaxel, carboplatin, and the initial cycles with pembro and followed by doxorubicin with pembro has been done. So with this population, they have taken the primary endpoint of a PACR rate. Comparison has been done in this group of patients. So the initial first interim assessment of this trial has clearly showed that the pembro plus chemotherapy has 14% more PACR rate as compared to placebo group in these patients. So that it has increased from 51% to 64%. And if we take it and compare with those of the PD-L1 status, so surprisingly, it has seen that in the PD-L1 positive, this increase was from 54 to 68%, that is around 14% improvement. But in PD-L1 negative group, there is a more marked improvement of around 18%. That is from 30% PACR rate, it has increased to 45% in this group of patients. So there is a definite for at least 14% improvement of PACR with the addition of pembro to this group of patients. So now in this year only the EFS had come at the interim analysis, and this event-free survival clearly shows that there is something around 6.3% increase in the disease relapse-free survival in this group of patients, and the event-free survival has also increased from 76% to 84% at 3 years in this group of patients. So if we see with the PACR rate, if the patient is having a PACR present in that group, the EFS is of the order of 95%. If there is no PACR, even in those groups, if we say pembro plus chemo non-responders are there, they have got a slightly better PACR rate as compared to placebo group, which has got 56 to 67%. So in all the groups, the PathCR rate has been found to be improved. So these are the initial studies which are being used in the early stage TNBC. The I-SPY 2 was the first study with Pembro use. They have used the Pembro for 4 cycles in this group with taxanes and anthracycline. And what they said, the PathCR rate is very much higher at 60% with, versus 22% somehow. So with the Keynote 522, which I've already discussed, is something the PathCR is 64% as compared to 51% in the control group. The IMPassion 31, they have also taken Atizo, and this Atizo has been used for 1 year. So also they have given something adjuvant therapies along with Napacli and doxorubicin and cyclophosphamide. So in this also the PathCR rate has increased to 57% as compared to 41% in the control group. The NeoTrip a PD-L1 study in which Atizo is further given for further 8 cycles without any anthracyclines with Napacli and Carbo. So here also there is a 4% benefit in C. The Durvalumab has also been studied as per the Japan Nugo study, and this also showed something around 9% improvement. And this study also showed a 3-year event-free survival improvement of around 8% in this group of patients. So the immune-mediated adverse effect, as already it is more or less same with few patients having infusion reactions. Hypothyroidism is still being the most common thing, apart from those the other endocrine deficiencies and pneumonitis occurring in few patients. The Atizo, the IMPassion 31 study, which is the addition of Atizo to the neoadjuvant chemotherapies. In this, nab-paclitaxel has again been used combined with Atizo, and in the second line, the chemo is AC followed by with Atizo, and they have also post-surgery. They have given an adjuvant dose of Atizo in this patient. And as discussed, the PathCR rate has increased from 41 to 57%. There's a 16.5% improvement. And in the PD-L1 positive patients, this improvement is higher in this group of patients, is around 49 to 68%, 19% improvement we are seeing. Whereas in the PD-L1 negative group, also there is an improvement from 34 to 47%. So in both group of patients, the PathCR rate is found to be improving in the case of neoadjuvant setting. So how to deal in the adjuvant setting? So as we know, we have got a data of Createx, which adjuvant capecitabine has been used in HER2 with those patients with TNBC with residual disease, with having a significantly improved 5-year disease-free survival, going from 89%, 74% as compared to standard of care 67%, and the OS is surely increasing by 89 months as compared to 83 months in this group of patients. So and it is seen almost in all the subgroups. So there is a study in gastric cancer of combining capecitabine with immunotherapy, and they have shown that it is a well-tolerable regime in the gastric, and the capecitabine has been combined with pembrolizumab. The adverse events are well matched. So you can also use a combination, but still data are lacking in adjuvant setting of combining capecitabine with immunotherapy in those group of patients. Similarly, the PARP inhibitors. So now the data for Olympia trial, which is showing the adjuvant olaparib versus placebo in BRCA1/2 mutated HER2. So they have shown its benefit in this group of patients that the invasive disease-free survival has improved by 8.8%. If we are using the olaparib in the patients who have got these mutations. So in that case, also if we have to add immunotherapy, so we have still data is less, but surely there is an offer. So what is the next? What is in the clinical practice? So in now clinical practice, if the patient is having T1C disease with node negative, in that case, you are going to give a neoadjuvant therapy with only chemotherapy. Either you may use a taxane along with platinum or only a platinum, only a taxane with AC versus TC. And in that case, if there is no PathCR, surely you are going to give a capecitabine with a BRCA wild type, and if it's a mutant one, then olaparib. Whether to add pembrolizumab is still few data are coming, but might be in recent years we are going to add pembrolizumab to either CAPE or olaparib in this group of patients. The other setting is if it is more than 2 centimeters, that is a T2 disease with any node status. In that case, you have to add immunotherapy to this, can add immunotherapy to the chemotherapy regime. And then depending on the PathCR rate, if there is a PathCR, you complete only with immunotherapy for 1 year. If there is no PATH-CR, depending upon whether to add only capecitabine or olaparib, and along with that pembrolizumab. So in the future, so this is going to be the treatment paradigm. The patient is completely affordable for all the things in this group of patients. The very early patients, if we say T1A or B, in which case when there is the very small tumor, surely if the patient go upfront surgery, thereafter you may take for the chemotherapy. Still the data for adjuvant immuno in this setting is for very early is there is no. The only problem with immunotherapy, I will say that these patients in the case of early stage are completely curative patients. So if these patients, there is still a chance the patient is developing an endocrinopathy, which may going to last long. So the toxicities, though they are less, but still they are present with the immunotherapy. So you have to choose your patients and have to monitor them very closely if when one is planning immunotherapy in this set of curative patients. So with the other trials which have been ongoing is about tailoring this neoadjuvant therapy response and to decrease even the dose of the further chemotherapy if the patient is having a good response. And if the case of BRCA mutation, it has to be the neoadjuvant in addition to the adjuvant PARP inhibitors is going on. So there are many clinical questions which are needed to present address in neoadjuvant immunotherapy, whether it will benefit all patients or we have to take few patients which have got a biomarker selection, have to balance the risk and the cost, who will be going to benefit, and the risk and the toxicity, that who can avoid immunotherapy also, because immunotherapy still have got some toxicities which are going to last long. Regarding immunotherapy, whether we can combine immunotherapy with AKT or PARP inhibitors, we have to see that. Optimal duration of immunotherapy, so all studies have now taken an adjuvant setting also along with the initial treatment. So we have to see whether the patient have achieved a PATH-CR or not, without a PATH-CR, how long to give. With the chemotherapy backbone, what we will see that optimal chemotherapy backbone, which is to be used in which patients, as we see that the platinum improves PATH-CR in initial studies and event-free survival, but does not have got an improvement in OS and further increases toxicity. So the chemotherapy backbone has also been to be taken care of. And there is some data regarding anthracyclines also modulating the tumor microenvironment. Further, there are role of antibody drug conjugates, which are now coming, like sacituzumab govitecan and trastuzumab deruxtecan in the low HER2 patients. And in the post-neoadjuvant therapy, so what will be the optimal one? And whether pembro plus other post-neoadjuvant therapies can be used or not? And what is the role of capecitabine in now in the adjuvant setting? So there are many unanswered questions which we are getting answers in the near future. So if but the most important thing that you have to engage your patient in all the discussion, you should tell the patient about the benefit and the toxicities of each therapy and what are their goals and what are the treatment goals and what are their concerns. And therefore, based on that, you have to take a decision what treatment one have to give to the patient. With this, I would like to thank everyone for this. Thanks.
Thank you, Amit. You are really, whenever you present, you make the presentation by heart always. And yes, this was a very good presentation for the integrating the immunotherapy in triple negative. And so now this was the last session of today's conference. Today's topic, breast cancer. Thanks to all the faculties who were the speaker, moderator, and the panelists for their wonderful participation and making the sensible this webinar sensible. And I think you can say that we can make the clinical notes also for the notes clinic purpose with all the topics. And I also thanks to Dr. Reddy's, Dr. and Zydus, for Cipla and that Biocon and other Novartis, Pfizer, and AstraZeneca, Merck, Ariet, and that means you can say other AstraZeneca and Cipla and Novartis for this wonderful participation, including Mylan and President Kavi with Sun Pharma and Intas. So, and also thankful to the organizing team, Horizon, who made this smoothly this today's conference. So now, good night to all.
Thank you. Thank you everyone for joining, and we'll meet again on 11th and 12th of November. Till then, goodbye. Good night.
Good night.
Technical team.
Yes, ma'am.
Yeah. Please.